Malaria and Diving by Drs. Frans Cronje and Albie de Vrij. Malaria can kill you. In fact, it's far more likely to do so than decompression illness ever will. And so the purpose of this presentation is to give you the hard-hitting facts that are relevant not only to traveling in Africa, but particularly when you are diving in Africa. Many of the recommendations are generic. However, there are some that are specifically relevant to divers, and that will be the focus of this presentation. Now, although it may seem easy to give recommendations regarding travel safety to people who intend to move through Africa and elsewhere in the world, it's actually surprising how many challenges there are. First of all, people don't necessarily seek advice, certainly not early, nor necessarily from a qualified source. And then, of course, the information they get may vary. Dr. Google is often consulted, and the information may be disparate, contradicting, and downright wrong. Will they actually prevent the diseases and injuries that they're supposed to try and avoid? How do you then ensure that people get the appropriate advice, particularly in a medical consultation that is of limited duration, and how can they be referred to appropriate educational resources? How do we ensure consistency in the advice obtained from a variety of sources? We frequently find that people coming from Europe versus those from the United States may not only have different recommendations, but often prescriptions for completely different prophylactic medications. And this may be not only because of the literature or the research or the organizations promoting a particular recommendation, but also because sometimes medication may not be available everywhere, or it may be more readily available or inexpensive in a particular location. How do we also ensure that special interest groups, like women and children, and divers, get the optimal protection? Well, this is one of the objectives that Dan has, and one of the reasons for this talk. The circumstances of a weekend trip to Mozambique or Madagascar, and that of a diamond diver in the Ivory Coast, are very different, and we would like to individualize. Now, for many people, there is simply something inherently unpalatable about taking prophylactic medication. The fact that much of the malaria medication is bitter doesn't help. And if anything, the many years of bush warfare and supporting United Nations peace forces in the tropical areas of Africa has taught us that people simply do not wish to take medication for an invisible problem, even if it's a deadly one. In this simple study, you can see that the recommendations for long-sleeve shirts, as simple a recommendation as any, has about a 50% compliance. One person has them, the other person doesn't. And it's so simple. For many years, there have been several published guidelines for prophylaxis of malaria in Africa. We will attempt to summarize the most recent recommendations with special emphasis on divers, and also extend these guidelines for a global platform. Although somewhat dated, this reflects the World Health Organization's depiction of the areas where malaria is distributed around the world. And as can be seen, Africa and Southeast Pacific have the greatest prevalence, and many of these areas also boast some of the most popular dive sites. So malaria is certainly a risk, whether the diving activities that are planned are recreational or of a commercial nature. The far greater risk than anything attributable to diving is the ever-present possibility of malaria. South Africa itself is quite fortunate in that malaria is largely restricted to the northeastern fringes of our country. Only tourists traveling to the Kruger National Park or the northern parts of KwaZulu-Natal are likely to be in need of prophylaxis. However, as you've seen before, the rest of Africa is free game for the Anopheles mosquito. The most recent guidelines on malaria prevention and treatment, of which the most recent updates were published in 2009 by the South African Department of Health, are sound scientific documents and provide generic advice which is relevant to most malaria areas in the world. They were produced by the National Department of Health and our Malaria Advisory Group. Having said all this, how relevant is the malaria problem? In short, enormous. In Africa, it is responsible for at least 5 times the number of deaths attributable to HIV. There are some 300 to 500 million cases per year, resulting in 1 to 2 million deaths. It causes enormous socioeconomic impact and affects not only travellers, of course, but the resident populations as well. Pregnant women, children, the elderly and the immunocompromised are particularly at risk. However, incidence amongst travellers is also on the increase, and recent setbacks of terrorism and fears of pandemic diseases have done little to curb this. All people entering a malaria area are at risk. Unlike many other diseases, malaria is not decreasing in Africa, and this is unfortunately even true for South Africa. This is a recent publication in the South African Medical Journal, and it offers a chronology of how malaria incidence has varied over the years. There was a spike in 2000 after a particularly wet year in South Africa, but the disconcerting thing is that malaria incidence has not returned to baseline. It has remained somewhat elevated. Of course, there are many other factors influencing malaria control, and these include the economic health of the respective countries and the quality of their malaria prevention and eradication campaigns. It also, of course, is related to the stability of their governments. And malaria does not respect country borders, and therefore the proximity to countries with poor control renders their neighbours vulnerable. Zimbabwe is a particularly relevant example of this. So much more does need to be done. The prevention strategies for malaria fall into 5 general categories, and these can be remembered as the A, B, C, D, and E. A and B are primary prevention, and the first step is awareness, without which none of the other precautions are likely to be observed. B is avoiding bites, the second step. C and D represent secondary prevention, in that the disease is already transmitted, but it is either immediately eradicated through chemoprophylaxis, or it is detected so early that complications can be avoided. E is effective treatment, meaning that complications may then be minimized. All plasmodia, which is the Latin name for the malaria parasite, follow the same basic life cycle. Starting arbitrarily at the point of the mosquito bite, sporozoites are introduced with an anticoagulating substance in the saliva of the Anopheles mosquito, and this is then absorbed by the circulatory system within about 30 minutes. Schizonts then develop in the liver and are released as merozoites into the circulation to infect erythrocytes or red blood cells. Hypnozoites, a dormant liver stage, may remain in chronic forms of malaria, from which outbreaks may occur for months or even years thereafter, unless it is specifically eradicated. Merozoites follow an asexual cycle of multiplication, so they are ultimately released with the rupture of the red blood cell, and this coincides with the fever spikes. The intermittency of these fever spikes often provides a clue as to the type of malaria involved, as the cycles vary between the plasmodial strains. Amidst the so-called asexual cycles, there is the development of the sexual gametocytes in the red blood cells. These must be ingested by a feeding mosquito to result in infection of the vector, in other words the mosquito itself, and eventually the next host. Fertilization occurs in the intestine of the mosquito, with sporogeny, which is the formation of the sporozoites, which then concentrate in the salivary glands of the mosquito to be released during the next feed. And as you probably know, only female mosquitoes require blood feeds for the maturation of their eggs. This is a simplified diagram and explains the life cycle of the malaria parasite in a way that's easier to grasp. As can be seen, there is the skin phase, the liver phase, and the blood phase. And barrier and chemoprophylactic measures are designed to deal with these respectively. The best intervention is to avoid mosquito bites. Popular and commonly recommended measures include gauze mesh on doors and windows, wearing long-sleeve shirts, using 10% DEET or DEET, burning mosquito coils, using mosquito nets with insecticide, pyrethrin knockdown sprays used with windows closed just before retiring, and dusk to dawn avoidance of exposure, or adequate coverage. Now, if one considers the barrier versus chemoprophylaxis measures, the following are relevant considerations. First of all, is it a malaria area? And if so, what are the chances for contracting malaria? For instance, an air-conditioned hotel does not present the same risk as a bush camp. If malaria were to be contracted, what is the risk for neglect, progression, or complications? So essentially, the final decision is reduced to malaria risk versus drug risk. Now, importantly, even if chemoprophylaxis is indicated and taken, barrier precautions should never be neglected. This graph provides a useful objective comparison between the risks for contracting malaria versus the risks of having a serious drug reaction to a common malaria regimen that ultimately requires hospitalization. In other words, it compares the chances of getting serious malaria to getting a serious drug reaction. And the break-even point is around 1 per 10,000 or 10 per 100,000. So in other words, 10 per 100,000 is the risk of a malaria drug causing hospitalization. And therefore, in situations where the risk for contracting malaria is greater than 10 per 100,000, the risk for malaria is greater than the risks of taking the drug. So from this graph, it can be seen that travelers to the Solomon Islands, Papua New Guinea, or tropical Africa will have a greater risk for contracting malaria without chemoprophylaxis within 2 weeks. And this is therefore more likely than getting an adverse drug reaction. So, clearly, chemoprophylaxis in these areas would be indicated for all but the briefest of trips, and even then, a very high index of suspicion would need to be observed after the trip. Conversely, trips to Central and South America, as well as Southeast Asia, will only carry a higher risk for malaria than having a drug reaction after 3 to 4 weeks. So, if one were to go for only 2 weeks, the chances of getting a bad reaction due to the drug would be greater than the chances of contracting malaria. Now, the incubation period for falciparum, which is the most severe form of malaria, is between 7 and 30 days. In other words, within as little as 1 week to as long as a month, someone may start developing symptoms of falciparum malaria. Chronic malaria may have longer latencies, and this must also be factored in terms of the risks and, of course, access to treatment. Traditional recommendations up to 2003 have included a variety of agents, but ever since 2004 there have essentially been 3 choices: mefloquine, of which the trade name Lariam is perhaps the best known, doxycycline, and atovaquone preguanil in combination, sold as Malarone in the United States or Malanil in Europe and Africa. Mefloquine, or Lariam, has the advantage of being more than 95% effective in eradicating chloroquine-resistant Plasmodia falciparum. The disadvantage, though, is that it may cause vestibular, in other words dizziness, or psychiatric side effects, and it may be confused with decompression illness. It does have a convenient weekly dosage, and the advantage that it can be taken relatively long-term for 6 months to even 2 years. The dilemma, though, is to determine whether it's safe and that an individual does not have side effects. But this causes some problems. Firstly, if side effects were to develop, they may persist, often up to 4 weeks, which means that if an experimental trial of this drug is used and the person has side effects, the side effects may persist and disqualify them from diving anyway. Secondly, some of the side effects may not develop immediately, but only develop after 3, 4, or even more weeks of use, and therefore the drug is somewhat unpredictable. For the most part, this drug is not recommended for pilots or divers. The only exception we would make is that individuals who have been taking this drug for a significant period of time and wish to undertake diving and have not had side effects at that point need not be disqualified from diving. But we would never advise someone to start taking Lariam prior to undertaking a dive trip. It's simply too unpredictable, and the hazards outweigh the benefits, because there are alternatives available. Doxycycline, which is related to the tetracycline antibiotic family, is also more than 95% effective towards falciparum malaria. It is only suppressive though. In other words, it relies on an effective immune system to do its job. It also serves as simultaneous prophylaxis towards tick bite fever or rickettsia, cholera, and E. coli or bacillary traveler's diarrhea. It has relatively few side effects, of which sun sensitivity is perhaps the most common, and sun protection factor 30 or higher is recommended to be used concurrently if taking doxycycline chemoprophylaxis. It can also cause gastrointestinal upset, usually in the form of heartburn. It may interfere with oral contraceptive drugs, and it may cause candida overgrowth as a result of the antibiotic effects. There are some important contraindications which would not specifically be relevant to divers, and those are pregnancy or breastfeeding, because it concentrates in bone and in breast milk, and for the same reason, children below the age of 8, because it concentrates in their growing bones and may stain their teeth. Malarone, which is a combination of atovaquone and proguanil, is 98% effective in the prevention and treatment for falciparum malaria. The benefit is it is actually parasiticidal. In other words, it actually kills the parasite. It is therefore recommended primarily by the Center for Disease Control for chloroquine-resistant malaria. It is suitable for adults and children over 11 kilograms or 25 pounds, and there is insufficient data in terms of pregnancy and breastfeeding, although it does not appear to cause any abnormalities in the fetus. There is an obvious caution towards those who may be hypersensitive or have renal problems, and it requires a daily dose, which is started 1 to 2 days before travel and should be continued to 7 days after the exposure. In this sense, it is beneficial and superior to the other drug agents, which need to be continued for at least 4 weeks. It is also the only drug that is parasiticidal. The others are suppressive drugs. Its only major disadvantage is cost. It is far more expensive than the others, and may be harder to come by in certain cases. The only side effect that we've really been aware of in divers is mild vulnerability to motion sickness that seems to be exacerbated with Malarone relative to the other drugs. Now, there are some potential alternatives that are just listed here for completeness. Azithromycin, better known as Zithromax, primaquine for the liver phase, its analog tafenoquine, and dapsone, which has been discontinued largely, although may still be recommended in places like Zimbabwe. Its complications exceed its potential benefits, but if there's nothing else, it is something to be considered. There are several factors that may determine the ultimate choice of one of the 3 drugs of choice that we mentioned earlier. And these can be summarized by the so-called 6 Ps. Firstly, pregnancy or breastfeeding women, palpitations or heart disease, psychiatric illness or epilepsy, pediatric patients, and porphyria and psoriasis, which are skin conditions. These may result in the selection of one of the 3 drugs above the other. So for divers, which mostly exclude those suffering from 6 Ps, the primary consideration is the so-called psychomotor or neurocognitive side effects and the way it could interfere with nitrogen narcosis or possibly oxygen toxicity. Gastrointestinal side effects may have a greater safety implication to divers. Sun exposure is of course highly likely for divers diving in the tropics. Fungal infections are perhaps more common in divers, and of course remote locations require very effective prophylaxis, particularly when there are poor medical facilities, which means that standby treatment would also be advisable. So, what do divers choose? Well, for the most part, the first choice is doxycycline. It's more than 90% effective and can be taken for the duration that would be typical for a dive trip. The next would be Malarone and Malinol, because it's also very effective. unfortunately somewhat expensive, but it does not cause the neuropsychometric problems in pilots or divers. We don't have sufficient data in terms of its use at extremes of depth or commercial diving, but there's reason to believe it would be safe. Lastly, mefloquine, but only in the case of individuals who are already taking it, have had no side effects, and wish to undertake diving. So, bearing in mind the risks of malaria, the risks of chemoprophylaxis are actually relatively minor. Nevertheless, one needs to be careful not to make blanket recommendations and tailor it to the individual, even the non-drug measures. One should weigh the risk for the development of malaria as well as access to effective diagnosis and treatment. There are some additional notes. People living in a malaria area do acquire a partial immunity, and therefore many don't use prophylactic measures as residents in a malaria area, but they respond promptly to any flu-like illness. Importantly, though, they lose this fairly quickly upon leaving the area, and some of the most serious cases of malaria we have seen have been in returning residents who've been away on holiday outside the malaria area and contract it shortly upon returning. Then there's the option of standby treatment, and this is almost universally recommended for travelers into Africa who will remain in the malaria area for longer than the shortest incubation period, which, in the case of falciparum malaria, is 7 days. In other words, if you will be in a malaria area for more than 7 days, in which the chances for getting it are high, and particularly if medical facilities are unreliable, then standby emergency treatment is required. It is recommended that you have information on the 3 primary agents for prophylaxis readily available. For most unselected individuals, Malarone is now considered the first choice. Modern medicine has now provided us with a rapid diagnostic test for malaria, which is quite sensitive, in the order of about 95%. But it is imperfect and should be repeated if the signs and symptoms remain suspicious. It is of no value in determining severity or the effectiveness of treatment. And a positive test in a mild presentation signals the use of 16 or a 24-tablet regimen of coartem as a standby. This is one of several rapid tests on the market which either target plasmodial histidine-rich protein, 2-HRP2, or parasite-specific lactate dehydrogenase, PLDH. Now, one of the malaria myths that has killed many people is the notion that prophylaxis masks the symptoms of malaria and therefore may delay seeking effective treatment. While it is true that individuals taking prophylaxis may have a longer incubation period before experiencing symptomatic malaria, the course of their disease is more benign than the unprotected and less likely to have a disastrous course. Importantly, when considering the potential diagnosis of malaria, any flu-like illness, rigors, which essentially means shaking, sweating, tiredness, muscle aches, abdominal pain, diarrhea, loss of appetite, nausea and vomiting, coughing, plus a positive blood smear or positive rapid test in a setting where there's a high index of suspicion should prompt the use of standby medication and urgent assessment at a medical facility. So in summary, Plasmodium falciparum is the culprit for the majority of diseases. All travelers are non-immune to malaria. The diagnosis and management of any suspicious symptoms is urgent. The diagnosis is made via a blood smear or a rapid test. In the case of uncomplicated malaria, artemether lumefantrine or coartem or quinine plus doxycycline and clindamycin should be considered. There is the possibility of sulfadoxine pyrimethamine plus artesunate in Mpumalanga and Limpopo. But in severe malaria, quinine plus doxycycline or clindamycin should be considered. This is a summary of the flow chart for the treatment of malaria as promulgated since August 2002. Basically, the decision should be made whether or not a disease is possibly malaria, bearing in mind there should be a high index of suspicion. There should be an attempt to prove the diagnosis this way or that, and, based on the severity of the case, the introduction of the standby drug Coartem versus the more definitive treatment quinine plus doxycycline or clindamycin should be started as soon as possible. Just a note on HIV and malaria. Those who are semi-immune with HIV have worse attacks and higher levels of parasithemia. Non-immune individuals with HIV certainly have the highest risk for severe malaria. Malaria is a notifiable disease, and this means that it should not be ignored or be dismissed as having been trivial even if the standby medication eradicated the symptoms. It is important to know of the incidence of malaria. This is the only chance we have of effectively combating this disease. South African regimens may not necessarily be appropriate for malaria contracted abroad, for instance in Thailand, Myanmar or Cambodia. And the drug choice may indeed change over time. At this point, it's necessary to note that certain drugs either don't work or are best avoided, such as Fansidar, which has a very high resistance, mefloquine in the case of divers, halofantrine, particularly after someone has been on mefloquine, and chloroquine on its own. There may also be special cases in which there are either mixed infections of falciparum plus another form of malaria, pregnancy, and infants and young children. The following are indicators of severe malaria and should prompt urgent referral for medical assessment and treatment and even evacuation. A decreased level of consciousness, severe vomiting, diarrhea or dehydration, inability to take in oral medication, respiratory distress, circulatory compromise and shock, spontaneous bleeding, jaundice, and a parasite level greater than 5%. Malaria is a big topic, and for that reason we offer you some of the original references and encourage you to download these, particularly if you need to provide advice to travelers, divers, or tour groups. Some of them are available on the Dan Southern Africa website, and we encourage you to browse our website for a written version of this talk. We hope this presentation was of value to you, and we encourage you to still seek travel medical advice or a diving medical assessment prior to travel into a malaria area. There's always the option to call Dan, and of course there are resources on the website that we'd like to refer you to. Thank you for your time, and travel safely.